Today we'll be starting from growth hormone. Growth hormone er ekটু জিনিস বাকি ছিল. So the thing that were left was abnormalities which we were discussing. Okay, দাঁড়ি পড়ো. এই হলুদ জামা পরা মেয়েটা, তুমি তোমার ডান দিকে দাঁড়ি পড়ো, ডান দিকে দাঁড়াও। এই হলুদ জামা পরা, তোমার নাম কি? তোমার নাম বলো। পেছনে তাকাচ্ছ কেন? ক্যামেরার ঠিক ডান দিকে। হ্যাঁ, তুমি তোমার ডান দিকে ওই মেয়েটাকে দাঁড় করে দাও। দাঁড়ি পড়ো, সেকেন্ড মেয়েটা। ওই তো হলুদ জামা পরা, হলুদ জামা কে? ওই তো ওখানে। হ্যাঁ, তোমার ডান দিকে ওকে দাঁড় করে দাও। দাঁড়ি পড়ো, দাঁড়ি পড়ো। এ মা, দাঁড়ি পড়ো, তোমার ডান দিকে। দাঁড়িয়ে যাও, দাঁড়ি পড়ো। গুড, এইবারে চুপ হয়ে যাবে। নেক্সট, so I already talked about there is a special kind of growth hormone disorder. Next কান ধরে দাঁড়াবে। হ্যাঁ, চলো। So special kind of growth hormone disorder, that is your Laron Dwarfism. লেখো Laron Dwarfism. So what is Laron Dwarfism? So in this case, the growth hormone may be normal or may be high. So either high or normal growth hormone, so that there is no problem in growth hormone synthesis or growth hormone regulation. But the problem is they are receptors. So problem is receptor related. And the third thing is that IGF, insulin like growth factor, that becomes very less. So these three things are found in the special kind of dwarfism that is called as Laron dwarfism. Okay. So normally the growth hormone, they are either less or they are defective. But in this case, the growth hormone may be high or normal. Short question or short notes may come. In which kind of growth hormone disorder, okay, the growth hormone level itself is normal or high. Since the problem is completely receptor mediated, okay, that's why there is dwarfism. Because even if the synthesis and the regulation of growth hormone is okay, they are not received properly in their receptors, and that's why they are not be able to taken up and came into function properly. That is your Laron dwarfism. Okay, growth hormone level is either normal or high. So what is the treatment? The treatment is IGF analog. This insulin like growth factor, that is very low level, that is present in very low level in case of Laron dwarfism. So provide something called as mecasermin, MECA, meca, ACRMIN, mecasermin. Okay, hey bosho, mecasermin. This is insulin like growth factor analog. This is IGF analog. Synthetically produced outside, mecasermin. That is special kind of dwarfism, Laron dwarfism. So four kind of disorders in case of growth hormone we have discussed. First was gigantism, second was dwarfism, third was acromegaly, and fourth is Laron dwarfism. Okay, those three were synthesis related, and this is receptor mediated or receptor related problems. So these are the disorders of growth hormone. Next, another thing is, this is very new, recombinant. This is very new, newly synthesized drugs. So recombinant growth hormone, that is actually human. Just like human regular insulin, we have synthesized this drug. This is very new. This is under clinical trial. This is not approved drug, but this is under clinical trial. Recombinant human growth hormone. Okay, so that is new. They are tend to have three functions. First is anti-aging properties. So these, all of these things, these are not proved. Okay, these are under clinical trial. So they are thought to have anti-aging properties, recombinant human growth hormone, anti-aging properties. Secondarily, of course, in treatment of dwarfism you can use. And finally, treatment of muscle wasting. One of the main function of growth hormone was body bulk production, okay, muscle proliferation, body build proliferation. So in those patients who have muscular wasting, like muscle wasting like HIV, AIDS, or in case of tuberculosis in some cases, but that is noted to be, came in handy in case of AIDS, AIDS related muscle wasting. So treatment of muscle wasting, okay, in opportunistic infection like AIDS. So in this case also we can use this recombinant growth hormone, because growth hormone is known to have muscle building properties and muscle proliferating properties. So to oppose muscle wasting in case of infections like AIDS, we can also use, but all of this is under clinical trial. This drug is under clinical trial, recombinant human growth hormone. So that is all about our growth hormone. Only this much was left previous day, but since already 10 minutes have passed, post 10 I think, it's on Saturday, that's why এইটুকুই বাকি ছিল, but আমি বলিনি. That's all about your growth hormone. Secondarily, we'll be moving into your second twin hormone of growth hormone, that was prolactin. So second hormone is our prolactin. Prolactin, why does it synthesize from? This is synthesized in typically pituitary, but they are regulated by hypothalamus. Which hormone was stimulating it? I already told you in previous class, TRH, thyroid releasing hormone. This was not only affecting the TSH, but it was also affecting the prolactin. So this TRH comes into pituitary and they will cause the release of your prolactin from your anterior pituitary. Okay. That is your prolactin. The synthesis is from here, and the typical process, this TRH actually, they will come and they will stimulate specific cells. They will stimulate specific cells that are called, since that is prolactin, so the cells will be called just like corticotrophs, okay, somatotrophs, they will be called as lactotrophs. So lactotrophs in anterior pituitary. So they will stimulate the lactotrophs in anterior pituitary. They are called lactotrophs. So easy to remember, prolactin. Okay, corticotrophs, ACTH or cortical hormones. Then like somatotrophs, growth hormone. Similarly, lactotrophs will be, responsible for the synthesis of prolactin from anterior pituitary. So TRH positively stimulate lactotrophs, will be releasing prolactin. Another substance I told you on previous classes, maybe the name you don't remember, but those are called vasoactive intestinal peptides, VIP, vasoactive intestinal peptides. So just like growth hormone, there was a substance, there was a protein that was called, sorry, not protein, that is an enzyme. That enzyme was called ghrelin. So that ghrelin was individually, positively affecting the release of growth hormone. Similarly, these vasoactive intestinal peptides, they will be positively affecting these lactotrophs also. Okay, they will be positively affecting these lactotrophs. So two positive factors in case of prolactin. So just like previous class, just like growth hormone, by this chapter, by this graph bolte paro, by this chart, okay, we will be directly discussing the synthesis and the regulation. So first regulation is through TRH via pituitary lactotrophs. Second positive regulation is through VIP, vasoactive intestinal peptides, positive regulation on lactotroph proliferation, prolactin release. So two are positive affecting Similarly, 2 will be negatively affecting. So 2 negatively affecting factors will be there also. Taraki, one is this prolactin itself. Okay, prolactin itself means not itself, there was certain thing called as prolactin inhibiting factor. আগের দিন বলেছিলাম এটা আরেকটা নাম কি ছিল, ডোপামিন। Prolactin inhibiting factor or dopamine, I already told you in previous class. So that was inhibiting factor, so ki korbe, they will be negatively affecting it. Okay, and secondarily corticoids, glucocorticoids, and also the T3 and T4, they will be also negatively affecting this prolactin synthesis. Ki kore? So this T3 T4 actually they will be, if they are very more in number, not number, very more in amount. Okay, if they are very much in amount, this T3 T4, they will negatively affect this hypothalamus to release less of TRH, the typical negative feedback control. Okay, T3 T4 is too much, so thyrotoxicosis that might happen, or any kind of syndrome, any kind of problem can happen due to increased level of thyroid hormones. So they will be negatively affecting the hypothalamus to release less of TRH, less of thyrotropin releasing hormone. In turn, they will be releasing less of TSH and less of T3-TR. Typical negative feedback loop. Okay, so by that way, they will indirectly cause the suppression of TRH. So that's how. But TRH যদি কমে যায়, if the TRH is suppressed, automatically, since TRH was positively affecting, prolactin will also be suppressed. So that's how these T3, T4 glucocorticoids, they actually affect negatively. So two positive factors, vasoactive intestinal peptides and TRH, these typical two positive factors. Two negative factors, glucocorticoids and T3, T4 and prolactin inhibiting factor or dopamine. So this is the regulation as well. Okay, this is the synthesis and this is the regulation. Jodi bole we discuss the regulation of prolactin hormone. So if you provide this chart, that will be enough. That will be enough. এখানে তুমি কি দেখাচ্ছ, the synthesis you are also showing. Okay, the way they are also synthesized, the cells that are affected, এগুলো সব তোমরা show করছো. Then you are also showing the negative factors in the chart also. Okay, so these things will be enough not only for the synthesis but also for the regulation of prolactin hormones. Just like the growth hormone, একই রকম আমি চার্ট দিয়েছিলাম, so like those charts will be enough for regulation also. This is the regulation of prolactin hormone as well. ঠিক আছে? Now next thing is we will be moving on to functions. Regulation হয়ে গেল, synthesis you know, now we will be moving on to functions. What are the functions of prolactin? Functions of prolactin will include first lobulo-alveolar growth of breast or proliferation of breast. So first function lekho, first function is breast. So proliferation of lobulo-alveolar growth. There can be two kind of growths that may be seen in a breast. একটা হচ্ছে ductal growth, একটা হচ্ছে lobulo-alveolar growth. All of this will be discussed in details again in your reproductive system also. Reproductive physiology under আসে, pregnancy, lactation. So those things will be discussed in details. For now, just know they actually support the breast by proliferating the lobulo-alveolar growth. Okay, proliferation of the lobulo-alveolar growth and resulting in increased lactation. Second function is actually, so this is a positive function. Second function is actually a negative function. This prolactin negatively inhibits your GnRH. Prolactin negatively inhibits your GnRH. এটা কি ছিল gonadotropin releasing hormone. So due to this, in return there will be very less amount of both FSH and LH, right? So GI RHS is less. So for that, due to that cause, both FSH and LH are very less. So they negatively inhibit the sexual factors. Okay. So this lower FSH, LH, lower GnRH, what will they actually precipitate? They will precipitate some typical factors. Okay. Typical factors. In case of females, they will cause, এটা কোশ্চেন আছে, শর্ট নোট আসতে পারে, explain why can come from this. The females, they typically suffer from lactational amenorrhea. Lactational amenorrhea. LH, we all know LH is very much important for your ovulation, for your bleeding, and FSH also is very much responsible for your menstrual cycle. So since both of them are suppressed, there will be amenorrhea. Amenorrhea means not presence of any menstrual cycle. So lactational amenorrhea, that means a mother who is in a lactating phase, who has a baby, okay, whom she is actively breastfeeding. In that phase, those moms will cause amenorrhea. Those moms will face amenorrhea. They will have no typical menstrual cycle. So dysmenorrhea না কিন্তু amenorrhea totally বন্ধ হয়ে যাবে. Okay, so বুঝতেই পারছো, when the woman is suffering from amenorrhea, that portion is very much important or very much significant for natural contraception. So this is also a natural contracepting method. So lactating mothers are often told that you are safe to have sex, unprotected sex, obviously. Why? Because they are naturally protected, because they are lactating. এই যে দেখো, growth hormone, sex hormones, they are getting suppressed. Since they are getting suppressed, there will be amenorrhea. If the mother faces amenorrhea, she will have no further complication related to contraception. So natural contraception is achieved during lactation. এইটাকেই বলছে lactational amenorrhea. Explain why can come, short note can come. In case of gynae তে mainly আসে, তোমাদের explain হয়ে আসতে পারে why lactational amenorrhea is caused. Okay, বা prolactin causes lactational amenorrhea, বা এভাবেও দিতে পারে কি breastfeeding females are naturally contracepted or naturally protected because of prolactin. এরকম ভাবে বিভিন্ন ভাবে ঘুরিয়ে কোশ্চেন দিতে পারে, একই অ্যান্সার হবে, এই সামান্য জিনিসটা লিখলেই হয়ে যাবে। ওকে, তো দিস ইজ দ্য সেকেন্ড ফাংশন। থার্ড ফাংশন হচ্ছে গিয়ে ইন কেস অফ মেলস, নাও সিমিলারলি ছেলেদের ক্ষেত্রেও প্রোল্যাকটিন থাকবে, বাট ইন কেস অফ মেল, ওকে, দে আর সাপ্রেসিং দ্য FSH, LH, they are suppressing the GnRH. তো মেলদের ক্ষেত্রেও এফেক্ট দেখা যাবে। সো 3, in case of males, typically prolactin causes loss of libido. Typically they will cause loss of libido. And finally আরেকটা জিনিস বাকি আছে, সেটা হচ্ছে formation of sperm, মানে spermatogenesis. Spermatogenesis is also suppressed. So suppressed spermatogenesis or inhibition of proper spermatogenesis along with loss of libido, that will be seen in case of males. So এটাও কোশ্চেন আসতে পারে। তো these are the functions, these are the typical functions. And receptor same, আমরা ডিসকাস করেছিলাম, just like growth hormone, they are twin hormones, so they show similar character. রিসেপ্টরটার নাম কি ছিল? সাইটোকাইন রিসেপ্টর। But they are after being received in the cytokine receptor, they are not activated. Okay, they are not activated. Activate হওয়ার জন্য আরেকটা স্পেশাল জিনিস লাগে, কি বলেছিলাম সেটা? Janus kinase enzyme. ওখানে ছিল জ্যাকস্টার্ট পাথওয়ে ইন কেস অফ গ্রোথ হরমোন, আগের দিন বলেছিলাম। Just like that, Janus kinase enzyme comes here, only then activation of prolactin. Activation of prolactin happens just like growth hormone. This pathway is called as JAK-STAT pathway. Same. So Janus kinase, so receptor is cytokine receptor. After being received, they will be activated by this Janus kinase enzyme. The pathway is called Janus kinase pathway. Similarly, it was also in case of growth hormone, similar জিনিস ছিল. After being activated, they perform those functions. Okay, in case of females, in case of males, in case of female, in case of breast, so they do all these functions, they perform. So that is all about your prolactin. Okay, আর ফাইনালি ওখানে ওটা বলেছি ইনক্রিজ ল্যাকটেশন, হ্যাঁ, মিল্ক প্রোডাকশন, অফকোর্স এখানে আরেকটা লেখো, ইনক্রিজ ল্যাকটেশন, ইনক্রিজ মিল্ক প্রোডাকশন অ্যাজ ওয়েল. So this is all about your prolactin, very important hormone. And finally you should know about, so that is the basic regulation and some factors. There will be some factors which will be increasing prolactin secretion, there will be some factors which will be decreasing prolactin secretions. কি আছে লেখো. So factors, also factors increasing prolactin secretion and factors decreasing prolactin secretion. এটা মুছে দিচ্ছি, এটা লেখার কিছু নেই, একই জিনিস. ওকে, সো এখানে আমি একটা টেবিল বানাবো, ওই টেবিলটা সবাই লেখো. So there is a table, increase this side and decrease this side. Okay, prolactin secretion factors. What are the factors? লিখে ফেলো. First, very easy, লেখো pregnancy and lactation. Whenever ovulation happens, a woman is pregnant, officially pregnant, only then the, so, and after also the birth of the baby, in both cases, pregnancy and after birth of the baby, when the baby needs to be filled breast milk, then in those periods, in those times, prolactin secretion is automatically increased. Second is your sexual intercourse. Sexual intercourse will increase prolactin secretion. Third, suckling of nipples. Suckling of nipples will be increasing prolactin secretion. Okay, so the babies, okay, বাচ্চারা when they actually produce this suckling of nipples, okay, তখন prolactin secretion মেয়েদের ক্ষেত্রে বা মায়েদের ক্ষেত্রে বাড়বে. Okay, and finally another thing is there, that was sleep. Just like growth hormone, the sleep, but in this case REM sleep. ওখানে উল্টো ছিল growth hormone. In case of growth hormone, it was just the opposite, NREM sleep. Okay, NREM sleep that was increasing and REM sleep that was decreasing it. But in this case, this REM sleep, rapid eye movement sleep, okay, that will be increasing your prolactin secretion, typically between 4 to 6 am. 4 to 6 am. ওই জন্যে, because of that the mothers are usually told to feed their baby, okay, around dawn or at night. Okay, because at the night, when the after REM sleep, the prolactin secretion increases. So of course the baby will have good amount and good quality of milk production ওখানে বেড়ে যাবে. যদি prolactinের function বাড়ে, both the lactation and both milk production will increase. So it will increase very well between or after midnight. Okay, when slowly or during dawn, when slowly your eye is moving, eyeballs are moving, rapid eye movement, not slow, very rapid movement, eyeball movement happens. So during REM sleep, typically between 4 to 6 am, the prolactin secretion is highest. Explain why can also come ki high prolactin levels are usually noted, okay, during dawn or around 4 to 6 am. Ki hobe same explanation, because REM sleep typically increases prolactin secretion, and that's why the breastfeeding is ideal time is between this and this. এইভাবে অ্যানসার গুলো যেরকম পারবে লিখে দেবে. But since REM sleep is usually seen between 4 to 6 a.m. So between 4 to 6 a.m. the prolactin secretion can also be seen at a spike. যেরকম অ্যান্সার হবে তোমরা লিখে দেবে, এক্সপ্লেন হয়ে আসতে পারে, দিতে পারে। Similarly, decreasing the prolactin secretion কি কি আছে? There are three factors. একটা অলরেডি তোমরা জানো, dopamine, typical prolactin inhibiting factor. It is the PIF itself, dopamine. There is analog of dopamine, that is L-dopa. L-dopa. That will also a chemical that will decrease the prolactin secretion. And third is bromocriptine. Bromocriptine, another substance that will be negatively affecting prolactin secretion. Dopamine, L-dopa, it is itself PIF, prolactin inhibiting factor, L-dopa and bromocriptine. Three factors decreasing prolactin secretion: pregnancy, lactation, sexual intercourse, suckling of nipples and REM sleep, especially between 4 to 6 a.m. okay, or especially around dawn. Okay, when REM sleep is usually at peak, the prolactin secretion will be also at their peak. Okay, ideal time to breastfeed is around dawn. So এই হচ্ছে all about our prolactin. Next we will be moving on to thyroid hormone. TRH নিয়ে কথা হচ্ছিল, thyrotropin releasing hormone. It was regulating our prolactin. So we will be moving on to thyroid hormone next. Thyroid hormone is typically released from which gland? বলো, এই কোন গ্ল্যান্ড থেকে রিলিজ হয় থাইরয়েড হরমোন? Thyroid gland. From thyroid gland. So from hypothalamus, so thyroid hormone from hypothalamus, from hypothalamus there was thyrotropin releasing hormone. Then there comes pituitary. From here on, TSH, thyroid stimulating hormone, that is released. They will come inside the thyroid gland. Okay, there are two kind of cells. Some cells are like this, big cells. Okay, they are called as follicular cells. So these are crystalloid type of cells. They are like crystals. Some boro cell thake, big cells. Okay, you will notice in case of thyroid gland, they are usually called as follicular cells. So these follicular cells are actually the most important, not the most important, they are the only cells. Okay, they are producing this T3 and T4, right? Now there will be another kind of cells. Okay, another kind of cells. So bolo egulo jodi follicular cells hoy, the cells around them eguloke ki bolbo? Very good, parafollicular cells. Okay, around, beside টার্মটাতে প্যারা শব্দটা ইউজ হয়, ঠিক আছে? সো parafollicular cells, just like paraventricular bodies, সেরকম parafollicular cells. So this is your paraventricular cells. So this paraventricular cell, sorry ventricular না, এখানে follicular আছে, এখানে হবে parafollicular cells. So typically the follicular cells are responsible for T3 T4 synthesis, but these parafollicular cells, they are responsible for very important hormone that is called as, that is related to calcium, calcitonin. They are calcitonin producing cells. So parafollicular cells, they are calcitonin producing cells, but follicular cells, typical big crystalloid cells, okay, they are producing this T3 T4. All of these are happening under the influence of TRH, first released from hypothalamus, and TSH, second released from pituitary. Ultimately এখানে কি হবে? T3 or T4. Okay, so this is the basic synthetic pathway or synthesis pathway of your thyroid hormone. Next, now synthesis basic. Okay, now we'll be moving on to details. Okay, the cellular level. In case of cellular level, একটা ফলিকুলার সেল আঁকো চৌকো করে, দাঁড়াও, draw this. So this is your follicular cell. Okay, this is your follicular cell. Now beside them, this is your blood vessel, this is your blood vessel, this is your follicular cell. Next, so here a lot of, not a lot of, a few transporters, okay, a few receptors, they will be coming into action. So first receptor here on is your, এখানে হচ্ছে কি সোডিয়াম আয়োডাইড রিসেপ্টর, okay, sodium and iodide. So first receptor coming into action is there is sodium iodide. That is not a typical receptor, that is actually a symporter. Sodium iodide symporter. Why symporter? Sim means they are moving sodium and iodine in same direction. Yes. So they are sodium iodide symporter. So for every one sodium getting inside, you will see one iodine on one iodine. একটাই হয়, হ্যাঁ, sodium and iodine is 1:1. Okay, one sodium ion getting inside, another iodine ion will be getting inside. Iodine বলে না, iodide বলে. So iodide ion. Okay, so this is your sodium iodine symporter. আলাদা করে লিখছি না, বোঝাই যাচ্ছে। Now you will see another thing also, that is sodium potassium ATPase. ATPase, sodium potassium ATPase function কি? Typically, okay, getting inside potassium ions while moving the sodium ion outsides. Typical ratio is 3:2. মানে কি, দুটো পটাশিয়াম ভেতরে এলে তিনটে সোডিয়াম বাইরে যাবে। So 3 sodium ions gets outside, 2 potassium ion gets inside. That is sodium potassium ATPase pump. That is a pump. Okay. So two factors here. এই যে সোডিয়াম গুলো যাচ্ছে, so when these sodium ions become too much, কি হবে? This ATPase pumps them outside and restores the normal amount by replacing them with potassium. Okay, because usually sodium বেশি সেলের মধ্যে যাওয়াটা সেফ না, তো কি হবে, sodium potassium ATPase will be removing the excess sodium outside and will be replacing with 2 potassium by this sodium potassium ATPase pump. Second hole. Third, there will be another thing very important, এটার নাম হচ্ছে iodine and chloride. So chloride iodide antipode again. So this is pump, ATPase pump, this is antipode. Okay, so এই যে আয়োডিনটা যাচ্ছিল, this iodine now comes outside and to replace this একটা ক্লোরাইড আয়ন ভেতরে ঢুকবে। So that is your sodium iodide, chloride iodide, যে কোনো নাম দিতে পারো। ওকে, এটাকে আমরা অ্যান্টিপোডও বলতে পারি। আরেকটা টার্ম আমরা ইউজ করতাম এক্সচেঞ্জার। ওকে, একদম প্রথম চ্যাপ্টারে বলেছিলাম অ্যান্টিপোড এন্ড এক্সচেঞ্জার হ্যাজ দ্য সেম মিনিংস। অ্যান্টিপোড মিন হচ্ছে একটা দিকে যাচ্ছে একটা দিকে যাচ্ছে, and exchanger means the same, they are exchanging ions, one iodine outside, one chloride ion inside. So that is your chloride iodide antipode. এটা আরেকটা নাম আছে, that is called pendrin. This antipode has another name, that is called pendrin, PNDRIN, that is called pendrin. Okay, pendrin এই নামটা মনে রাখবে। Why একটু পরে বলছি। So this antipode has special name, that is called pendrin. Pendrin is nothing but a chloride iodide antipode or chloride iodide exchanger. তিনটে হলো। Now the function comes, এখানে কি হয়, সোডিয়াম ঢুকলো আয়োডিন ঢুকলো। Okay, this extra sodium, if the sodium is excess, they are being replaced by potassium. If they are not excess, they remain like this. So what happens to the iodine? What is the fate of this iodine molecule? This iodide, they get exchanged by a chlorine or chloride ion bhetore dhukbe, and iodide they get outside of the follicular cell. They get outside of the follicular cell, and এখানে তোমার কি হচ্ছে this, so this iodide, this is not in oxidized form, this iodide, this is now in a reduced form, this is a reduced form, so it needs to be oxidized. They will get oxidized by a typical enzyme called as TPO. Full form is thyroid peroxidase. Lekho thyroid peroxidase. Thyroid peroxidase. Okay. So this reduced iodide will be oxidized by TPO, that is typically called as thyroid peroxidase. Oxidized hole ki hobe I2. Okay. Iodine holo form holo. Now another thing you have to remember, so a lot of factors are coming. Okay. So secondarily, so first তোমাদের দুটো জিনিস খুব ইম্পর্টেন্ট, একটা হচ্ছে আয়োডিন, ওরাল আয়োডিন থাকতে হবে, তার মানে বুঝতে পারছো this iodine will come from where, this iodine will come from where, from food, okay, from diet. So first is iodine from diet, and secondarily a molecule is very important, that is your thyroglobulin. Thyroglobulin. So from this thyroglobulin, okay, one protein is derived, that is your tyrosine. So this chemical tyrosine, SIAD, this chemical tyrosine from thyroglobulin and this iodine from your diet. So what is important? Good diet and having this thyroglobulin in your body, in your blood. Okay, from this diet you will get this iodine, and from your thyroglobulin you will get this tyrosine. Now you can say sir tyrosine kothe theke elo? Of course tyrosine has the function, this tyrosine will help this iodine to be stored. কিভাবে এখনি বলছি, সো এটা আলাদা করে লিখছি না, tyrosine from thyroglobulin. Now এগুলোকে মুছে দিই, how this tyrosine now is coming along. So most important factors for this thyroid synthesis and storage is iodine from diet and thyroglobulin producing tyrosine. Okay, so now এখানে এই যে আয়োডিনটা আছে, it will get attached with either monothyroxines or complicated না করে আমরা এখানে this iodine plus tyrosine will have different molecules produced. Okay, so এবারে দেখো এখানে কি হচ্ছে, এই জিনিসটাকে now this iodine is getting with your tyrosine, this term is called as organification. কি বলে? Organification. So what organification is happening, এবারে তোমরা বুঝতে পারবে কেন. Now after combining with tyrosine, they can be combined as multiple in 3 categories. First category is the most common, lekho monoiodothyronine, tyrosine and iodine, monoiodothyronine plus diiodothyronine. They will be produced in কটা আয়োডিন আছে, মোনো আর ডাই, থাইরোনিন, তাহলে কি হবে, রেজাল্টেন্ট ইজ T3. দুটো ডাইআয়োডো and monoiodo, both of them will combine to form T3. Second, DIT, এটা বলো কি হবে, প্লাস ডাইআয়োডোথাইরোনিন, কি হবে, দুটোই ডাই আছে, তাহলে T4. Okay, but another thing is very important, DIT plus MIT, তোমরা এগুলো পড়েছো কেমিস্ট্রিতে, আইসোমার এর, ওকে, আইসোমার পড়েছো তো, দিস ইজ নাথিং বাট অ্যান আইসোমার. দেখো এখানেও MIT প্লাস DIT T3 হচ্ছে, বাট ইন দিস কেস DIT প্লাস MIT, ওকে, আইডিয়ালি T3 হওয়ার কথা, সেটা 2+1 না, ডাইআয়োডো প্লাস মোনোআয়োডো, বাট নো, এটা স্ট্রাকচারালি এটা ডিফারেন্ট হয়. সেই যে LD তোমরা ওখানে পড়েছিলে, ইন কেস অফ ক্লাস 12 ইউ হ্যাভ স্টাডিড LD, এখানে দেখো একটা লিখেছি তোমার L ডোপা, ওরকম. সো দ্যাট ইজ একই জিনিস, the structure is same but the orientation is a little bit different. তো এটাকে আমরা নাম দিয়েছি রিভার্স T3, reverse T3. So what is the function of this reverse T3? This reverse T3 is actually is a form of T3. Whenever this T3 synthesis is too much, whenever there is thyrotoxicosis, whenever there is excess production of T3, body ki korbe? Body will reverse it. Body will form this reverse T3. Now this is the inactive form. This is the inactive form. This is the actually inactive form. So your body needs to, newly generate the inactive form, so that the activity of this thyroid hormones or T3 doesn't suffocate your body, doesn't affect your body. So in some cases, whenever there is too much synthesis of T3 or T4, body might change the formation, change the synthesis into inactive phases. Okay, so body তখন কি করবে? এই যে T3 টাকে inactive form হিসেবে রাখবে. They will be collecting them with as inactive form, so that এটা কোনো toxicosis না করে বা এটার কোনো ওভার অ্যাক্টিভিটি না হয়. All the thyroid hormone will be used. After that, they will be broken down and taken into action accordingly. Now তুমি বলছো স্যার এই যে একটা inactive form আছে, দুটো অ্যাক্টিভ ফর্ম আছে, এবার এটা কি হয়? They will be all of them together. Now they will go into, now all of them three, they will together, they will travel into your again inside, they will travel inside. Okay, এখানে ইনসাইডে ট্রাভেল করবে এন্ড বলেছিলাম কি ভেতরে এখানে colloid shape they are stored, so they are stored as colloids. They are stored as colloids. So whenever our thyroid hormone is needed in our body, there will be colloid breakdown. There will be colloid breakdown. Next din আমরা discuss করব, but very important. Okay, very important. Only 1% of all of these hormones are actually in our active form. Only 1% is on active form, and other 99% is inactive form. Okay, either they are like this, or maybe they are in T3 T4 form, but they are bound with certain proteins. So there are certain binding proteins. Next day আমরা discuss করব, just একবার নামগুলো এখানে লিখে নাও. There are certain binding proteins, okay, like albumin, like globulin. Of course এখানে গ্লোবুলিনটার নাম হচ্ছে TBG. TB মানে হচ্ছে thyroid binding. Okay, thyroid binding globulin. So albumin, thyroid binding globulin, আর আরেকটা আছে সেটার নাম আছে প্রি অ্যালবুমিন. এটা আরেকটা ভালো নাম আছে, এটা পরে আমরা ডিসকাস করব, তখন বলবো. নেক্সট ডে আমরা ডিসকাস করব, স্যাটারডে আমরা সেদিন ডিসকাস করব. বাট জাস্ট নামগুলো মনে রাখো, অ্যালবুমিন, প্রি অ্যালবুমিন এন্ড গ্লোবুলিন. গ্লোবুলিন কি? গ্লোবুলিন thyroid binding globulin, TBG, thyroid binding globulin. So either they will remain in RT3 form, or they মানে reverse T3 form, inactive form, or they will be reverse. কেন দেখো এখানে DIT আর A plus MIT ছিল, এখানে MIT plus DIT ছিল, জাস্ট ওটা স্ট্রাকচারটাকে রিভার্স করে দিয়েছে. this T3 becomes inactive, reverse হয়ে যায়. So either they remain in the inactive form, or they will be remain as T3 and T4 combined with either albumin or pre-albumin or thyroid binding globulins. So whenever they are combined, okay, they cannot perform. They always, when they need to perform, they need to be detached with these proteins, and finally they will be either keep in touch with these proteins, not keep in touch, keep together. Either they will be remaining together with these proteins, or they will be stored as colloids inside the follicular cells. Okay, so getting out of the follicular cells, getting oxidized, okay, combination with tyrosine accordingly, T3 T4 RT3, then getting back into the follicular cell itself again and saved as colloids. When body needs this excess amount, only 1% is active, other 99% either they become bound with these things, or they remain as colloids. Whenever body needs, this colloid breakdown will happen, and colloid breakdown এর পর ওরা বডিতে চলে যায়, only 1% active and 99% inactive থাকে, ঠিক আছে? So this is the basic of your thyroid hormone synthesis in cellular level, okay, cellular level. Sodium iodine is important. Potassium sodium potassium ATPase pump, 2 potassium inside, 3 sodium outside, okay, to negate the excess sodium entry. Ideally sodium bhetore thakbe. Now this iodine, 2 potassium is getting this sodium, okay, 2 potassium is replaced by 2 sodium, 1 sodium extra, he is also getting out by this sodium potassium ATPase pump. Iodine তাহলে কোথায় যাবে? Iodine is getting outside via this chloride pump, not pump, chloride iodide antipode, or simple name is your pendrin, okay. Finally this reduced iodine, that is with the help of thyroid peroxide is getting oxidized into I2 form. They will be combining with tyrosine. Tyrosine comes from thyroglobulin, and this iodine comes from your iodine from diet. Okay. So the tyrosine and iodine, they will combine with each other, forming monoiodothyronine diiodo. Di plus mono is T3. When diiodo comes first, the structural change happens and there is reverse T3. 2-diiodo will be tetraiodo, of course T4, okay. So all of them, either they will be remaining with the proteins, okay, form conjugated terms, and they will remain like that, albumin, prealbumin and thyroid binding globulin, or all of them will come inside, keep on remain as colloids, and if the body needs, the breakdown happens. Usually only 1% of all the synthesized ওই যে এত কিছু ফর্ম হলো, among them only 1% is active, all the others are either inactive or kept inactive by binding with the proteins, or kept inactive by stored as colloids. Now this is storage. You can also ask, sir কতদিন থাকে? This storage actually is enough for 2 to 3 months. 2 to 3 months, ঠিক আছে, 2 থেকে 3 মাসের জন্য এটা এনাফ।